Dr. Deepa Hans ma'am, Professor, Dr. Bhavneet ma'am, Assistant Professor, Shri Ashok Kumar ji, Senior Lab Technician, Shri Rakesh Rana ji, Senior Lab Technician, and Mr. Zahir Ahmed ji, Lab Technician.
Can play a part and help you in the laboratory. As we all know, with automation we would have a faster turnaround, faster results within 20 minutes, and not compromising on the technology because you follow the Westergren method itself. Enhanced accuracy because avoiding of pivoting errors or tilt angle variations, integration with the lab information system, minimal sample volume, high throughput, and closed tube sampling so that you're not avoiding any biohazard exposure to the staff. The limitations of manual method are known to all of us. Firstly is the time taken. It's a 1 hour time which is taken for a simple test as in ESR. The manual documentation, we rely on the manual documentation and keep a timer there and record the readings. Or the use of dedicated citrated tubes, you need to buy the tubes accordingly, transfer it on the particular tubes and then do the testing. Temperature fluctuations and the impact on the readings is a well-known fact. And no provision for any hematocrit correction or sample identification or a traceability of the result. And also it leads to waste generation, which again is a risk of infection. So these are all the so-kind available limitations in the manual method. We have a couple of instruments which are there to ensure that we cover the entire segment, right from the laboratories which have a lower workload, and the first step of automation to move from manual on a lower workload could go in for this Make in India product, which has got basically for 10 channel slots, and this is suitable for all the smaller labs which you would like to use, and there is no need of any separated samples because you could use your primary vacutainers can be placed directly in these particular tubes. As a touchscreen interface with 20 minutes results, just correlating with the Westergren method, and also you are able to see and QC graphs for this 30 samples per hour throughput, and there's no consumption of blood. The same tube can be again used for any of the tests for your tests in the hematology. So here is no wastage of the sample. This is the next slot on the batch analyzer. As the workload improves in the laboratory, you need a faster TAT. This is for having a batch of approximately again 30 slots can be placed, so 60 tests per hour is the throughput. Again, this is a Make in India one, and the instrument has a mixer and a printer. So initially when the tubes are placed and the primary vacutainers are placed, the entire sampling mixing is done of the particular samples. The sensor reads out the initial reading, and after once it's the entire process is over, sedimentation is done, towards the end another reading is read, and then the results are given. So practically within 25 minutes even the report is generated. So this is a faster TAT. There is no deviation from the Westergren method, it's only speeding up on the technology. HCT correction, standardization and mixing of samples, temperature correction, so to ensure that at any time we are having a reading which is very reliable. And the documentation of reports, you don't need anybody coming out there because automatically the printout will be out, so that's saving the time. No calibration, it's an optically calibrated one, and no need of any citrated tubes, and a dry technology because there is no sample or reagent consumption, no waste generated. So that's the advantage with shorter TAT. You have an option of batch and random, LJ charts can be seen, LIS connectivity, and good data storage. The consumables are these kind of a smart cards which are loaded with a certain number of tests. So based on the exhaustion of these, a new card will have to be taken. Then otherwise, apart from the controls, there are no consumables at all. This is the high-end one where you're looking out for automation and higher, bigger throughput labs, like around 250 plus or so, and you would need a faster TAT. So out here you can have a loading of approximately 216 sample tubes. As you can see, even pediatric samples can be loaded. Good high accuracy, and real-time monitoring of the samples can be seen. Here you can see in the dashboard exactly where the tube is at what stage, so it's very clearly visible to check out for any time. And any detection of lipemic and hemolyzed samples are also noted. Standardized mixing and positive identification. If through LIS you can even identify whether that particular sample is for ESR or not. If it is not marked, it will not be taken inside for the testing. And again, there's no reagents or additional cleaning solution, no additional consumable. And you can even recognize the test tube based on the type of model it is. Any mislabeled tubes can be identified and kept aside. Good correlation, and you also have remote assistance on this particular system. It's compatible most of the racks, so if at all you have the racks for the hematology analyzer, you can just take it, put the tubes in that and just slot it in the system and it can work with those racks. So that's how convenient and fast it is. Inside the analyzer, as you can see, this is how the chamber looks, and there's a belt where when the tubes move slowly. There are sensors at 4 places which is recording the readings at all times. And finally the report is generated. These are the devices, the consumable which is used basically, again a test card which is loaded with a certain number of tests, and this is to be used when it is consumed or purchased. It's got a very good correlation, around 0.96 Spearman's coefficient correlation. It's done with the manual method, and this is the kind of automation which generally saves us time, and these are available. It's a good benefit to the fraternity basically to utilize such instruments which are maintaining the accuracy and the correlation, and also giving you the time to the staff to devote for better other productive works in the laboratory. Thank you. With that, I come to the end of my discussion.
Sincere thanks to Ms. Archana for presenting a very good topic and very informative, and moreover there is no question about it, there is no doubt about it that automation is better, not better than Western grins or normal traditional method is better than automation. Definitely it has high throw output, eliminating the human errors, and it saves the time also, and the external influences, external factors like temperature, vibration, they do not affect it. So I would like to know the only cost per test. What is the cost effectiveness of this? Cost per test of the?
Ma'am, it varies basically. If it's on an outright basis, it's really economical. Especially for a smaller ones, yeah, it's just in a single digit or slightly more than that. Okay. For a smaller one, depending on the workload. And if it's a placement, yeah, the whole thing's fluctuations accordingly.
Yeah. Okay. Thank you. Thank you.
Thank you, ma'am, for such a wonderful session. Definitely, automation can streamline our workflows, minimize errors, as ma'am said, and also it reduces the manual effort which we are putting in. So, apart from that, ma'am, there are some challenges also associated with this automation, which we need to keep in mind.
I didn't get your question.
Ma'am, the challenges in automation, or what we need to keep in mind, like its implementation, or
I really do not see much of challenges out here. I mean, like in far as automation, it can only speed up on the thing, because I don't want to say this, but manual has its limitations for known reasons. So for there, at least you have a benefit, but. So for me, as such, I see that I don't see any drawbacks or limitations or not. It's only saving time and your efforts basically. And for a simple test like this,
yeah,
which can be done.
Thank you so much.
Thank you so much, ma'am.
Thank you for your valuable inputs. Ma'am?
Just a few clarifications in your first topic, and I think that is very important. What are the limitations of RET-HE?
RET-HE. Limitations I am unaware, sir, because based on what this whole parameter when it was introduced, it has only been of a clinical advantage, because especially for distinguishment, like I said, on functional and or iron deficiency, classical iron deficiency, it's only been helpful. I wouldn't know, I mean, apart from the fact that you're doing on a RET mode, if that is the limitation, then that's it. Otherwise, I'm not aware.
What I have got information from your this discussion.
Okay.
Is that microcytic hyperchromic occurs only in iron deficiency,
Okay.
or they might happen in iron restricted anemia. There are no other conditions. What about thalassemia?
Red HE has been recorded even for thalassemia. That paper which I had shown, sir, has for, it's got its range for base thalassemia trait, for ACD and iron deficiency. But that's a part of where that particular scientist has worked on.
You see the basic, you see if we have to see the how this is red HE, how this is calculated. The calculation is
Yes.
based on the light scatter
Yes.
properties of the reticulocyte,
Yes.
which has a direct influence
Mhm.
on the size of the reticulocyte. So therefore, if the anemia is microcytic,
Mm.
it may be seen in other situations where the functional iron availability or iron deficiency may not be truly reflected. At the same time, if folic acid is deficient, macrocytes,
Yes.
the amount of hemoglobin in the reticulocytes will be a bit larger.
Yeah.
And then red HE, which shows either normal or elevated.
Yes.
But in those situations, if the patient is iron deficient as well,
Huh.
how we can identify?
You would have to see in totality with the markers, no, sir? We're not debating that.
So basically, these parameters, they show only what is happening during last 1 to 3 days.
Mm-hmm.
You see, then there are other parameters, delta HE.
Yes.
You did not speak
Yeah.
on that. It's very red HE will be reduced. You see, you have to, I think the PGs should know that the basic how these red HE, it is the reticulocyte hemoglobin equivalent,
Yes.
and it is every time reflected or it is based on the size.
Hmm.
If the size is bigger, red HE will be enlarged.
Hmm.
But iron deficient patients may not show that in red HE.
Yes, yes.
So therefore, these are similarly in anemia of chronic disease. You said this will be elevated. No. You see, it will be elevated. But what about those anemia of chronic cases who are iron deficient as well?
I totally agree. You would have these kind of cases. And that is the reason we need more of paper and abstract and validation
No.
of similar disorders
We have to
come to
understand
conclusion.
these parameters very well because we are seeing these in thalassemia patients. So it is very important there. And another important in sepsis, you did not highlight, the monocyte differentiation width.
Yes.
It's
Yeah,
one of the
that's one
important
instrument, only one
parameters
instrument.
for sepsis.
Yeah, true. That's there in one of the instruments only. But majority of the others, what they have right now is imagograms, which is a easier marker. That's
Similarly, neonatal sepsis, you did not highlight those.
true. IT ratio.
You see, there is a inflammation and there are bone marrow changes and how we can detect. So those are the features which must be understood very well before one has to interpret these newer
True,
parameters.
true. I truly agree, sir.
This is very
Truly agree, sir.
Right.
In fact, we would like such kind of scientific abstracts and publications in different scenarios so that we have a better picture of what happens exactly. Thank you. Thank you for it.
Thank you. I now request the chairpersons to kindly felicitate our speaker, Ms. Archana Ravindranath.
I request Dr. Meena Sidhu ma'am and Dr. Abhimanyu sir to present mementos of appreciation to our respected chairpersons. Dr. Deepa Hans ma'am, Dr. Bhavneet Kaur ma'am, Shri Ashok Kumar ji, Shri Rakesh Rana ji and Mr. Zahir Ahmed ji.
Yes.